and answer any questions that come up from the patient's perspective. So feel free to just put anything in the chat, ask away. I'm happy to be a resource for everyone. And I guess I can get started with my story, basically from when my symptoms started all the way through where I am now in my journey with endometriosis. So I was 13 years old, and that's when I first got my period, and it was absolutely awful. And not just because I was a 13-year-old with my period, and I thought it was the worst thing in the world. I truly experienced a ton of pain. I had a very heavy period at 13. I was going through pads in my pants, and it was super embarrassing, of course, at that age. And I always suspected that something was going on. My mom took me to an OBGYN with whom she was very familiar, and I ended up being put directly on birth control, basically with no questions asked. So I was on birth control for 5 years, and I started realizing and just being a bit more in tune with my body and kind of understanding that maybe it was the birth control that was making me feel the way I was. So I decided to come off of birth control. I had a conversation with my doctor at the time, and she strongly advised against it. But I was like, you know what? I kind of just want to see how my body feels without the birth control and see how I'm doing, both mentally and physically. And not that long after, I had an ovarian cyst rupture. So, and the way I figured that out actually was I was in so much pain. I was doubled over. I couldn't stand up and walk on my own. And I went right into the emergency room, and they did uh, an abdominal ultrasound and transvaginal ultrasound, and they were able to see that I had a significant amount of fluid in my abdomen. And they said, you know, the likely case here is that you had an ovarian cyst rupture, which is very painful. So basically, what my doctor said was the reason it probably ruptured is because I came off of the birth control, which was likely keeping those cysts at bay from rupturing. And so it was kind of a matter of whether I was going back on birth control or not. And because my cycle was regular, I didn't really feel that I needed to be on birth control because, again, it didn't make me feel very good. So I ended up just, not going back on birth control, trying to manage my symptoms. I was still having abnormally heavy periods. And oftentimes my symptoms were written off as being normal. It's just a heavy period, or it's just normal abdominal pain with your period, or it's just the normal backache, normal fatigue. And I can tell you from experience that nothing about it was, in fact, normal. If you're experiencing that kind of pain, that kind of fatigue, it's always important to be an advocate for yourself and make sure that you are with care providers that are willing to listen and also understand that not every doctor is a specialist in certain areas. So doing the research on your own or asking for referrals to specialists, I think, is really important. And I think Dr. Sproley can agree with that. When you go into the emergency department, they're really looking for what is imminently threatening to your life. And while a period might be very painful, it's not something on the outside that could be threatening. It could be something else that might be threatening that's associated with that. So fast forward, I was going through years and years of this pain and advocating for myself, with no answers, right? It was just, oh, you had another ovarian cyst rupture. You just have to get through the pain and, it was very difficult. Like I was changing, transparently, I was changing like a Super Plus tampon often in like 30 or 45 minutes. Nothing about that's normal. That's, not how our bodies were designed to function normally as women. Um, so again, fast forward, um I was a very active person. I danced. I was pretty good about what I was putting in my body, nourishing myself, staying hydrated. And still, I was super fatigued, experiencing these symptoms and in tons of pain. And it just progressively got worse over the years. And I continued to advocate for myself. And I even said several times to my doctors, I think this could be endometriosis because, of course, you start Googling things, and Google is not a doctor, but you can kind of start like matching your symptoms up to certain things. And it's always good, I think, to present what you feel might be wrong with your body because you're the one experiencing it. You're the one who's most in tune with what you're going through. Um, and a lot of times I was just written off and it was, oh, it's just another ovarian cyst. And I was like, I know that there is something more wrong with my body than just a cyst rupturing. So when a cyst rupture did take me to the emergency room a handful of times. But most recently, I was competing for the title of Miss Connecticut. And the night before our finals and crowning, I was in excruciating pain in my hotel bathtub, curled up in a ball, just hoping that the scorching hot water and being in the fetal position would make the pain go away. Um, and of course, the pain, it subsides, it becomes a bit more manageable, but it doesn't ever fully go away. And I just remember saying to myself, like, I don't know how I'm going to get up in the morning and compete and put my best foot forward. And I'm also a dancer. That was my talent for Miss Connecticut, for Miss America. And I just had no idea how I was going to perform a dance routine without injuring myself further. Um, so I got up in the morning, I did it somehow, and I was crowned Miss Connecticut, which was wonderful. So I was Miss Connecticut 2023. And during the entirety of my reign, not just because of my demanding schedule, but because of what my body was going through physically, I was completely fatigued. I was in pain all the time. I just remember like it wasn't just pain associated with my menstrual cycle. It was every single day of the month, no matter where I was in my menstrual cycle. I was in some amount of pain. And of course, that increased around my menstrual cycle. And I, continued to advocate for myself with my OBGYN. And a handful of times, the amount of pain I was in took me to the emergency room. And I just remember telling the doctors, I'm in pain every day of the month. It does get worse around my cycle. I tried to be as descriptive as I possibly could based on where I was feeling the pain, what type of pain it was, what I already knew about my health, because these are not your normal providers that have your whole list of diagnoses and what they've treated you for. They're not, super familiar with you the way your GP is or your regular OBGYN is. So it takes a lot more explaining and being very nuanced to kind of get your message across based on what you're feeling, what you're going through in that very moment. And it's important because they have to be able to figure out what is possibly going on. And I think, Dr. Emily, you might be able to speak a bit to that, right? um,
Yeah, absolutely. I mean, Gina, your story, if that's not an endo warrior, I don't know who is.
Thank you.
I've how much pain just the night before your huge crowning and performance. I mean, this is so typical of women, and I think this is why this diagnosis gets missed so often and for so long. So
Mhm,
many times, I mean, me as a doctor, endometriosis is one of the diseases that I know of that the time from initial symptoms to the actual time of diagnosis could be 7, 8, 9 years. There's really not that many other diseases out there, or illnesses or inflammatory conditions that go that long without being officially diagnosed, as we call it, with an official diagnosis.
mhm,
Tina, I want to like step back a little bit and unpack your story too. It sounds like at least in the emergency room, what we see is there's sort of three different kinds of patients, and an endometriosis patient can often be all three throughout the course of their disease. So, for example, you would start with the patient who has no idea what they have. They've never heard of endometriosis, they don't know what it is. All they know is they're getting these cyclical, painful pelvic pains, periods, horrible periods, their activities, they're unable to perform their activities of daily living, and they don't know why. They're going to doctors. Everyone is saying everything is okay. They're doing all their tests, right? That's one class of patients. Another class is the patient that maybe has heard of endometriosis or maybe had a family member with it, and they think they have it, but they don't have the diagnosis. And it sounds like you sort of had a transition period and you were kind of living in that stage for a
mhm.
long time, it sounds like, right?
Yep.
Then the final patient who has the diagnosis, did either the biopsy or did the surgery themselves. That's typically the gold standard for diagnosis of endometriosis is the surgery to actually see the endometriosis lesions in the peritoneal cavity. That's a final class, right? And so you kind of were experiencing all three throughout the course of your illness. Can you tell us a little bit about your care team that was involved? It sounds like you had lots of doctors sort of in and out of this whole process, primary care, OBGYN, emergency doctors, perhaps some other holistic folks, eventually a surgeon. Can you share a little bit more about your care team and kind of who you had to interact with?
Yeah, absolutely. Um, so I'm really glad you asked that. So I think initially, of course, this started with an OBGYN. And that's when I was put on birth control to kind of just manage the heavy periods and manage the cramping and the typical normal pain that, we all hear about. And then that kind of evolved into when I had my first cyst rupture. I went right to the emergency room because I didn't know what was going on with my body. I didn't even know what an ovarian cyst was. And I had to be very careful because, like I said, I was very active. I was a dancer. I was often performing. And when you're so physically active in that kind of a way, you're more susceptible to these cyst ruptures. Like the smallest movement can cause a cyst to rupture. And I had no idea that I even had ovarian cysts at the time. So um, that's where I was diagnosed with the ovarian cyst rupture. And over time, it just kind of evolved again. I had that monitored by a regular OBGYN. I was talking to my general practitioner. Of course, we were doing labs and blood work, basically just like your typical, your B12, your iron. Um, and I was begging my OBGYN at the time for a hormone panel. And I was very specific about the kinds of things I wanted tested. And I even mentioned, like, I think I have endometriosis. And many of the top indicators that Dr. Goldstein ended up testing for were never tested previously. Um, so my care has kind of evolved and, and gone through stages, and it really has taken a lot of advocacy, self advocacy on my part. And I think one of the biggest reasons that I continued advocating for myself was because this year will be 3 years ago, I lost my mom to bladder cancer. And I recognize that oftentimes women, and most specifically moms, put their own health on the back burner to take care of other people. And it's a really beautiful and it's a noble thing, especially when you have kids to care for, to make sure that they're taken care of, but it can be detrimental to your own health. So I think the biggest message here really is to advocate for yourself. Make sure that if you're experiencing anything that doesn't feel normal, anything that's abnormal, out of the ordinary, even if it ends up, being told to you that, like, yeah, this is a normal thing that people experience, it's better to be safe than sorry. And so when I lost my mom to cancer, I was just that much more like gung ho, if you will, about getting to the bottom of what had been going on with my body for so long. And my call to action was losing my mom to cancer, and then, of course, continuing to experience these awful symptoms where I just didn't feel like myself. It was very hard to get out of bed in the morning. You start kind of thinking that you're crazy because it's like, oh, everyone else is going through this, and you're dealing with these horrific symptoms that you just start living with, I think is the best way to kind of explain that. And you start thinking that it's normal to be in that amount of pain all month or during your cycle, during menstruation, and it's not. So this last time I had just gotten back from competing at Miss America, which was it was an incredible experience on the surface. But what I was going through during that week was managing my symptoms, managing my mental health because of those symptoms, managing a very demanding schedule. I mean, we were up at the crack of dawn every morning and didn't go to bed until after midnight. And for someone with endometriosis, especially in that late stage, is horrible because all you feel like you want to do is sleep so that you can, you know, either get through the symptoms you're experiencing or try to catch up on sleep because you're so overtired all the time because your body is just stuck in this really vicious cycle of trying to power through the day. Um, and so when I got back from Miss America, I was going to the emergency room on average about 2 times a month. And finally, in the third month, I said, something's got to change here. I called my OBGYN. I let them know everything that um, was kind of discussed and tested in the emergency room, which they did a ton of tests. They did all kinds of blood work. They ruled out an ovarian torsion and appendicitis through several different tests we did. It was crazy. And this was every time I was in the emergency room, by the way. So it was abdominal ultrasound, transvaginal ultrasound, um, MRI, CT scan, all kinds of things. Um,
And
and
everything,
everything was coming back normal,
of course.
right?
Yeah.
So I appeared in their eyes to be a healthy 29-year-old female. But under the surface, and you could kind of see different pockets of endometriosis, but it couldn't officially be diagnosed.
Yeah, exactly. And yeah, we can dive into kind of why that is, and I love your story, Gina, even though obviously you went through so much, it's so exemplary of how this gets missed in the emergency room.
Mhm.
I think we can take a minute to kind of unpack why that is.
Mhm.
Most times when patients end up in the emergency room, it's because they're afraid and they don't know what's going on. There's something going on in them that they cannot understand. Ooh, Dr. Goldstein has
Dr.
joined.
G.
How are you?
So we're just
Great. How are you?
I'm good. So sorry I'm late.
no worries. We just heard from Gina and we were just chatting about what actually happens in the emergency department when folks come in and kind of what we're equipped to deal with. Gina was sharing that she's been to the ER multiple times, always had normal workups there, normal tests.
Mhm.
It was basically a pin cushion, it sounds like, and I think a lot of our listeners can relate. to all the testing that you get done and then get told everything's fine. So we were just kind of diving into that. So when patients come into the ER, like we were saying, the emergency room is one of those places where what we're there to do is to rule out if there's something imminently life-threatening going on. Is there something, frankly put, is there something going on that could kill this patient imminently? That's what we're equipped to really discover and to investigate. Something like endometriosis, one of these illnesses that now we've just discussed, is something that can go undiagnosed. It can be missed for years and years. The emergency room and the emergency setting is definitely not equipped to really dive in and give the patients the answers that they really need or that they're looking for. We can certainly treat the pain, and I'm sure Gina can attest to that. I myself had been a patient in the ER with my endometriosis pain in my own ER. And yes, the medications work. And then you go home and you're sort of still left with this big question of what's going on. So when we come to the emergency room as a provider, as the one who's actually seeing this patient, it really matters how the patient is actually presenting and what kind of pain they're having in that time, because that's going to direct me to think about all these possibilities that, yes, it could be endometriosis. If it's in a patient who knows she has endometriosis or is highly suspecting it, sure, it could be that. But technically, although endometriosis is, of course, bothersome, it's horrible, it can really affect your life, technically, it's not an imminently life-threatening illness. So my job is to rule out anything that else that it could be. So for example, a ruptured appendix could be something that would threaten your life. An ovarian torsion could be something that would threaten the blood supply to your ovary and possibly lose an ovary. Something even more serious or totally unrelated, like an infected kidney stone, also looks like endometriosis. So what the main issue with endometriosis in the emergency room and why it tends to be such a foggy situation for so many patients is that it's the great mimicker of so many other diseases that we have to make sure that you don't have any of those things before actually coming up with a final diagnosis of endometriosis. So when, for example, when I was actually preparing for this and I was chatting with a lot of my colleagues and we were just kind of for fun looking up what's called a differential diagnosis for something like pelvic pain, which is the list of possibilities of what a patient's pain in the pelvic region that looks and sounds like endometriosis, what it could be, we came up with 46 different things other than endometriosis that we would have to think about as an ER doctor to make sure that the patient doesn't have these other things and can safely go home. So it tends to be really complicated. And Gina, we were talking about it a little bit earlier as well, that what ends up happening is, okay, the ER doctor says, hey, look, I don't really know what's going on, but here's what's not happening. And it seems like you're okay. Here's the results of your ultrasound. You're going to have to follow up with your specialist. And then it's on the patient, unfortunately, and the way that our healthcare system is made to follow up and to really know where to go. And if the patient has no idea, how to direct their care next, then we get this problem where patients are undiagnosed for years and years until they see someone like Dr. Goldstein who can actually help at the end of the.
Yeah. And then maybe I'll just jump in. Now seems like a good time. So I can go through a couple of things where endo can be, um, more emergent. And so in case there's any confusion about that. So things that would be more emergent for endometriosis. Endometriosis can cause a blocked kidney or hydroureter. It can cause kidney failure or renal pressure if there's endometriosis. That's actually causing a blockage of the kidney and the ureter outlet, which is the pathway from the kidney to the bladder. Endometriosis commonly affects the ureter. And so if there's bladder endometriosis, endometriosis of the ureter, and it is affecting the kidney's ability to excrete urine into the bladder, then that can become a more urgent situation with endometriosis. I've also seen obviously many cases of endometriosis seeding the diaphragm, and we've had patients with sudden pneumothorax or lung collapse with endometriosis. Again, it's not commonly associated with the lung collapse. However, there are many patients that may have endo of the diaphragm that will feel chest pain, shortness of breath, rib pain, and that may bring them to the ER. And they may have a chest X-ray that's normal. They may even have a CT of the chest that's normal. Sometimes they can pick up a nodule in the diaphragm, but not always on that imaging. And it doesn't mean, that there's not endo, unfortunately. It just means that it wasn't picked up on the imaging. And so even when patients are having those symptoms, I always think it's a great idea if you do go to the ER or your home to track when they're happening, what day of your cycle you are. And then if you are having shortness of breath, to have the chest x-ray and document it, keep a copy of it and know when that happened on your cycle. And that's super helpful for surgical teams like myself and cardiothoracic surgeons that work on this, that we can look at all those symptoms and look at when they're happening. And so the other thing that is a more urgent situation with endometriosis that would prompt something to do in the ER would be a ruptured endometrioma. And that's not something that everyone will operate on right away. However, I can tell you as a surgeon that deals with this, we don't want to let endometriomas rupture and have that fluid go all over the abdomen and be left there. Why? It splatters everywhere. It can go everywhere from the bladder up to the diaphragm. And we think that that cystic fluid over time could turn into sticky glue like adhesions or endometriosis lesions in the future. And so it's our preference not to let endometriomas rupture, to actually get them as they're rupturing or before they rupture, and do it in a controlled manner that you can actually suction all that fluid out and wash out the pelvis without having that spread and go all over the place. So those are some situations that I would definitely, that could bring patients into the emergency room and could prompt a more urgent surgical situation for endometriosis. So most of the time, it's not an urgent surgical situation. We need to plan it, and it's good to plan endometriosis surgery and have the right team and have bowel surgeons available and everyone you need. But those are a couple situations where it might prompt something through, the emergency room. So
Right, exactly. Yeah.
the other ones, but
Yeah. No, I mean, I think that that's a perfect explanation of kind of what the trajectory of what the patient might be experiencing, right? The ones that are having their chronic pelvic pains coming into the emergency room, like Gina was multiple times per month, without really knowing what was going on, not
Mhm.
really having any of these other more serious, imminently life-threatening complications, and then being sent home without any specific answers or really any direction on how to follow up.
Right.
Yeah,
And
and
then it's important, I don't know if you guys mentioned, but it is hard to get MRIs done in the emergency room. Usually you guys reserve those just for neurology cases where people are having acute paralysis. And those are the cases that can get an MRI done in the emergency room. As you can imagine, anyone that's had an MRI, they take over an hour to do. And so in the emergency room, you can get things like x-rays and ultrasounds and CT scans, but MRIs are usually reserved for, brain injuries, right? And more complex issues like that could be done immediately. MRIs of the pelvis can be done on an outpatient basis. So usually it's actually very hard to get an MRI of the pelvis done in the emergency room. So I have patients that ask that sometimes, well, can I go to the ER? Can I get an MRI there? I really would honestly prefer we do it on an outpatient basis. And I have an MRI facility that reads endo all the time, and they're super detailed with it. And so I'd rather do that and have an MRI at a place that really looks at endo all the time than a random ER where they're going to be doing a quick scan just to make sure there's no acute nerve issue or bleeding issue, and then get them out of there, and it won't be as detailed for endo. So it's actually okay in my perspective that it's not done in the ER. I prefer to have a more detailed facility that does endo a lot.
right, that's exactly correct in the emergency room. All the different types of imaging modalities that we have, they serve different purposes. The x-rays that you mentioned, the ultrasounds, the CAT scans, the main purpose is for us to figure out, is this something imminently life-threatening, or is the patient having a dangerous problem right now that needs to be addressed right now? MRIs are correct. Yes, they are very useful, or they can be useful in endometriosis. It's one of the only, I believe, and you can correct me if I'm wrong, one of the only imaging that could be mo the most reliable in terms of actually finding some sort of endometriosis diagnosis or finding. But we don't have those in the emergency rooms typically, for exactly the reasons that you said. We're reserving those for people who have strokes, people who have spinal cord injuries that might result in paralysis for the rest of their life. And then, as you mentioned as well, on the back end, when the radiologist is reading them, The radiologist is an emergency trained radiologist. They're not looking for things like endometriosis. They're looking for things that are completely unrelated most of the time. So they wouldn't even really give you a useful read, I think, on your MRI.
Mm. Yeah. Yeah. Absolutely. And we have some questions. Let's see, are endometriomas the only cyst that can rupture, since we just talked about cysts? So no, absolutely not. You can have, so actually I like to say this all the time to patients. Gina, I've told you this before, but cysts, when you are not on birth control and you're ovulating and you're having a menstrual cycle every 28 days or 30 days, you're actually ovulating every month, and every month you produce an ovulation follicle that grows from about 3 or 4 millimeters up until 2.5 centimeters, and then it ruptures. So every month when ovulation occurs, that's actually a cyst rupture. And the ovulation cyst ruptures and the egg is released, the follicle fluid is released into the abdomen. It's not a perfect ice cream cone where the tube picks up the follicle perfectly into the tube. It's actually floating, and the fimbria of the tube pick up the egg, and draw it up the tube. And so every month that happens. And some patients with endometriosis may actually feel pain with every ovulation. So every month they may feel that pain. And when we go into the emergency room and they do a scan, and then they say, oh, there's some fluid around the ovary, you had a cyst rupture, you know, in some other words, they're actually saying as well, you ovulated, and it's not always said that way, but I think it would be helpful for patients to tell you that is that every month when you ovulate, you actually have a cyst rupture. And so, no, not all, I mean, all cysts can rupture, and there can be an ovulatory cyst that stays around. It doesn't leak all its fluid properly one month, and then it can grow a little bit larger and a little bit larger, and that's a clear fluid cyst, and that can rupture. And that can create pain and pressure, and peritoneal signs or swelling in the abdomen or a little pain in the abdomen from the irritation of it. And so you can feel that from a clear cyst, you can feel it from endometrioma cyst, and really any type of cyst that would rupture from the ovary. But it is important to know that you do have a cyst rupture every time you ovulate. So.
Yeah, I would love to chime in too, and I think Gina could probably give her experience as well in terms of how the patients actually look, in my experience, when they're coming in with a ruptured cyst versus just an endometriosis flare and they need pain management. Usually, if you had a cyst that ruptured, it's usually a sudden onset, sharp pain. As Gina was sharing before earlier, it is more common in perhaps after some sort of mild trauma, dancing, an accident, exercise, intercourse. Sometimes the patients will come in with this sudden onset, what's called unilateral pain. So to be on one side of your abdomen as opposed to kind of all of it. And it will feel different. And what the patients describe to me is it does feel different from their typical endometriosis type pain. It's typically more sharp, typically more on one side. And as Dr. Goldstein was saying, when the fluid is sort of leaking out into the abdomen, they're much more tender on my exam as well when they have that fluid there. So even a small push on the abdomen will cause a lot of significant pain, as opposed to maybe previously when it was just their endometriosis pain, maybe a little bit less pain when I'm pushing on the abdomen directly. So these are some kind of key things to think about for you as a patient if you're sitting there wondering, hey, is this something different than my usual endometriosis pain? And Gina, maybe you want to chime in about your experience with pain in general and what you experienced.
Yeah, absolutely. I I like to think I have a high threshold for pain, which is not necessarily a good thing, especially when it comes to endometriosis, because then you kind of just start to lead yourself to believe that any level of pain is like normal and acceptable. And so when I was younger, I would, take a couple Advil and didn't really know any better, and it wasn't super helpful. But when I did initially, when I was like, 18 years old or so, and I had my first ovarian cyst rupture, is what I was diagnosed with in the emergency department. Um, I just, I was doubled over in pain. I didn't know what to do to manage it. I felt like I was going to throw up. And there really wasn't much to be done in terms of what could be given to me because I'm also allergic to, the more serious, like heavier drugs, like codeine and other opiates and things like that. So I couldn't be given something that would in a small dose, of course, like help manage that level of pain. And I think also too, we have to be very realistic and honest with ourselves about, the pain scale, where we're falling on that 1 to 10. And there were plenty of times that I was left completely breathless by the amount of pain that I was in. And that's kind of how I knew I was at like that 9 or 10 range and really couldn't even stand up and walk on my own. But there were other times where, to Dr. Emily's point, it was a bit more localized until my abdomen was pushed on by a doctor, and that kind of, sent more pain signals to my body. And I just knew it wasn't normal to be feeling like that. So, and fast forward to when I got back from Miss America and I was in the emergency room like 2 times a month. Um, I remember driving myself to the emergency room the last time I went before I discovered Dr. Goldstein, and my hands were frozen on my steering wheel because I was so numb. My body was numb from the amount of pain that I was in, and I was so dizzy. And it wasn't even safe to drive myself at that point. And luckily I was like just pulling into the parking lot at the emergency room, and I remember just running hunched over into the emergency room trying to get any sort of like immediate relief from this that I could. And it was like the pain was just blinding. I just remember it being blinding, and I just felt so dizzy, and I just wanted so desperately to be helped and to be listened to. And at that point, I was extremely emotional about it. I'd been communicating with my regular OBGYN for such a long time about the pain I was experiencing. And after a few visits to the emergency room explaining my symptoms, she finally said, I think you at least have stage 2 endometriosis, but I'm not a specialist. And so if we end up doing the laparoscopy, we might have to call in the oncologist. And being that my mom passed away from cancer, it really hit me in that moment. I was like, I need to continue advocating for myself. No matter what happens, I need to find a specialist for this, because I didn't want to be under anesthesia with someone who didn't know whether they could fully treat my case or not, honestly, at that point, because I think there's something to be said about the laparoscopic surgery being the gold standard for treatment. And if that is the way that you're going to go, you might as well be with someone who performs this surgery on a regular basis, like Dr. Goldstein. And then at that point, I had been referred to a different endometriosis specialist. It was going to be months before I got to see him. And after some research, I figured out that the method by which he treats endometriosis patients was not what I wanted for myself. And I think your direction of care truly is up to you and what you feel is best for your body. And at that point, I knew it wasn't how I wanted to be treated, because it involved possibly sending my body into menopause at 29 years old. And I knew that wasn't for me. So I continued researching. I found Dr. Goldstein, and I just remember looking at Dr. Goldstein's website and the SA Care website, and I felt such a relief come over me, because there was so much educational information that I had never seen before. And I was taking good inventory of the different symptoms I was having. For example, I was also having some gurgling in my sternum, and just different things that I never really recognized could possibly be cueing me into understanding that what I was experiencing was endometriosis. There were certain inflammatory conditions I had been going through for a number of years without answers. And once I found Dr. Goldstein, I finally got got my answer after a ton of testing. But I do want to see what's in the chat.
Oh yeah,
Uh,
there's lots of questions here. Okay, let's see. So, when to have surgery, when to go to the ER, what symptoms are a red flag. So definitely on these red flag symptoms, when is pain too much? We have someone asking about bowel symptoms and when is pain too much. I mean, I think when, what Gina talked about, what Dr. Esparola talked about as well, is that when the pain is very severe, very sharp, you're having trouble getting through a sentence, you can't eat, you're feeling nausea, vomiting, you're not feeling well, you're not able to tolerate food because it's so extreme. Um, your belly is very swollen. Maybe you can't have a bowel movement for several days. On top of that, maybe vomiting, any of those things like that could be triggers to go to the emergency room. You're feeling weak, faint, lightheaded from the pain, and unable to like um, really combat it at home. Some of the things I recommend, even with ovulation or cyst rupture or severe menstrual pain, is alternating pain regimens with Tylenol and Motrin. If you're doing that at home, is actually staggering them, not taking them both at the same time, but doing Motrin and then, 600 and then which is 3 tablets, and then 3 hours later you can do Tylenol. And we do this as a post-op pain management regimen. But if there is an extreme pain episode, you can try to tackle these things at home and hydrate and get these medications down with some food. And if that's not helping, and then you're still having the severe pain, you're vomiting, you're dizzy, lightheaded, things like this are bothering you, then I would say that would prompt an emergency room visit. In my practice, we always like people to call us and tell us first, even if we're not there or I'm operating, we still like to have a heads up so we can help you manage your care at the emergency room. Even my patients that travel in from surgery, and people ask, how do you operate in LA, and have patients in LA and then you're in New York and na. I have, even in New York and Connecticut, I have patients that travel in all the time for surgery, and they may go home 3 days to 5 days later. So chances are, even if they go back to their local emergency room after surgery, I will still call their emergency room doctors, and I will call them up and I'll help manage their care from afar and say, okay, what are we doing? What are we dealing with? How are their labs? How are they hydrating? How are they peritoneal? How are they looking? What's going on? And you can speak to that, but I think that emergency room doctors are always very happy to speak to me, that I'm taking charge of the patient's care even from afar and helping them out and saying, hey, I have their op report and their pathology. This is what happened on the case. What's happening today? How do they look? Can I talk to them? And I'll call the patient myself and then help with their family. So, I mean, those are things that we can do from afar, and we can help organize and call the emergency room ahead and tell them that you're coming and what to look out for and what tests we want run. And I can organize that ahead of your ER visit if you call the office and you're a patient and things like that. And so those are options for helping coordinate your care when you are going to the emergency room. And then, some of the pain management options at home, like for endo, heat packs, hot baths with Epsom salts, alternating Tylenol, Motrin on a staggered schedule like that. Lidocaine patches they have at CVS. They're 4% lidocaine patches that numb, and you can put that on the lower abdomen. We can also do a compounded pain cream that you can put on a panty liner or put on your lower abdomen when you're having cramping. And those can work well, and we can put combined medications in there that work really well for pain. And treatment options besides chemical menopause. So I'm not a big fan of chemical menopause in endometriosis patients. I think only very short-term use in a limited population, sometimes during IVF for adenomyosis. There's a couple of indications that, I would maybe recommend it on occasion. But most of the time, there is no treatment. There is no medical treatment for endometriosis. That's important to note. There is management of endometriosis, and that is managing it with birth control or menopause or things like that. But that does not treat endometriosis, meaning it does not get rid of the disease. So there's no replacement for actually excising and getting to the root of endometriosis. Any medication that you're on, even if it blunts the effects of endo and you don't have symptoms anymore, that's fantastic. That's great. But it doesn't mean that it got rid of the endo and it's magical. Okay. And I've seen patients that have had Lupron for 10 years and birth control for so many years, and we go inside and there's still tons of endo. So those drugs, while they help the symptoms and they help suppress the period or the ovulation and they have their role, they don't actually make the disease disappear. And that's very, very important to note for anybody that's been misinformed about that. Okay. And I'm not going to say they don't have their role. They do have a role, and birth control has a role for patients that don't tolerate having a period and they want to suppress their period, for patients that have really heavy bleeding, for patients that don't like to ovulate or have had a history of cysts and endometriomas. We may suppress their ovulation with birth control, and so that they don't have to go through that every month. So there are definitely occasions where these things are useful, but they're not magical to get rid of endo. Okay. Um, and
As well and share just every single thing that Dr. Goldstein has said in terms of the treatment possibilities, when and to get surgery and what kind and all this. None of these conversations are happening in the emergency room. We don't have the specialist there. This would be a time to go and actually find the specialist to have these conversations, to start some of these medications, to get the referrals. None of that happens from the emergency room. Just to round out sort of what we would do and to even add to your list of maybe why you would go to the ER as well, I just want to chime in with bleeding. If you're having lots of vaginal bleeding as well, if you're seeing it, you're bleeding more than one pad or tampon per hour, that's also complicating everything. Or if there's a chance you could be pregnant, we would need to rule out something called an ectopic pregnancy. That could be something life-threatening as well. So if you're trying to conceive, you're not, maybe you had a positive pregnancy test at home and then now you're having lots of pain and bleeding, come to the emergency room immediately. In terms of the endometriosis part, though, I'm going to round out, like I said, those conversations and all of this, this is not happening, unfortunately, in the ER because there's folks like me there who are not endometriosis specialists. We can give you the information that we found, and then it's up to the patient, unfortunately, to take it to where they need to take it. And so I think, Gina, we wanted to hear a little bit about what your doctor sort of said to you before you found Dr. G.
Yeah, so basically there was no other course of treatment. It was either I got on birth control, I took Lupron, which is the what sends you into a chemical menopause. And I would have been left to wait several more years until surgery. And I didn't feel comfortable with that because I knew that I wanted to have children. I wanted to start a family sometime soon in the future. And I had gotten to the point where I was sick, gone through 16 years of these symptoms that progressively got worse and worse and worse to the point of vomiting, of nausea, of numbness in my hands, and severe pain that had me doubled over, and I couldn't stand up and even walk normally, much less try to speak a sentence. And so it really does get that bad. And I think sometimes people don't understand that, and they don't understand the fatigue and the mental and the physical battle that goes along with this disease. And I basically was left no other option other than to take medication. I was advocating for myself. I asked for hormone panels, and the things that needed to be tested transparently were not tested until I went to Dr. Goldstein. And finding her was truly a blessing in my life. And I tell her this every time I see her. I went into her office and I felt like I was heard and listened to for the first time ever since I was 13 years old, trying to navigate these symptoms pretty much on my own with very little support. Dr. Goldstein performed an ultrasound in office. She very quickly ordered an extensive panel of blood work along with my naturopath that I had started seeing. It was recommended like a couple months before my surgery that I go gluten-free. And fortunately for me, I already had in July of last year. So I'm almost a year into being gluten-free to help kind of manage the inflammatory response in my body. So when I went to Dr. Goldstein's office for the initial visit, she was extremely proactive. The blood work was done. The results were in by the time I got to go speak to her. And one thing stood out to me is that she is the only doctor, based on my symptoms, whoever tested my CA-125. Is that right, Dr.
Yeah.
Goldstein?
Yeah.
So your CA-125 typically could be indicative of ovarian cancer, and with endometriosis being the only known precursor to ovarian cancer, it's imperative that that be tested, and it had never been tested, no matter how much I advocated for myself with other physicians. So that was elevated, not to the alarming amount indicating ovarian cancer, but it was elevated.
Mhm.
And so finally, we determined that it was best to do a laparoscopic excision should there be endometriosis present, and there was extensively. So I had my surgery October 7th of 2024. 29 lesions were removed, and a very large endometrioma on my left ovary, which Dr. Goldstein is very brave and incredibly talented, because I was told by other doctors that my left ovary would have to be completely removed. She completely preserved my left ovary. My left fallopian tube did have to come out because it was so deeply infiltrated with endometriosis. Dr. Goldstein also had to remobilize my left ureter. The colorectal surgeon was involved in my surgery because I had endometriosis on my bowel, and I had symptoms leading up to my surgery with that. I could not be like more than 20 minutes from a restroom, transparently. It was embarrassing. It was scary. It's not how a 29-year-old woman, or really anyone, should have to live their life. Um, and there were just so many different variables. And I can tell you from a patient's perspective that the laparoscopic excision surgery truly is the gold standard, because I would not even be able to be on this call for an hour if I were in the kind of pain that I was in a year ago. And my quality of life has improved dramatically. I can walk around, I can talk, I'm not in an incredible amount of pain anymore. I do experience fatigue here and there, but I do truly believe that's because my symptoms were not managed for 16 years. So I will leave Dr. G
Yeah, and
chat
that's,
about
we're
that.
so excited you're feeling so well. That's awesome.
Thank
And
you.
that was something we forgot to mention earlier about that CA-125. There's a couple of different markers and things we can look at, and they still wouldn't be necessarily done in the emergency room, but we can look at that with a hormone panel ahead of surgery, and we do them all the time in our office, and we can run them for you ahead of your first visit. So we look at all of that. And those are not elevated in every patient with endo, but they are elevated usually with ovarian cysts or with adenomyosis or deeply infiltrating endometriosis. And so those are definitely things that we look at that can cause an ovarian inflammation. And so unfortunately, we will get kicked off in like a minute and 40 something seconds. You know, but we can wrap up about things that you can ask for in the ER. They may not do a full hormone panel in the ER if they don't think it's urgent or necessary then. But you can ask, your doctor to run it, or if you are having an appointment with a specialist or coming to see us, we're always happy to do one for patients. And I do like to look at hormone panels. I look at if things are out of range or not. I look at vitamins. I look at CA-125. I look at the ovarian reserve. Because a lot of patients with endometriosis may have issues with fertility. And so it's something even in young patients I like to track and follow and keep ahead of. And so I don't really agree with the recommendations never to check blood work. That's not my line of practice. But as far as the ER goes, I think documenting every time you go to the ER, right? If you can get your records, get your imaging, write down what cycle day you were. That's super helpful to surgeons like myself to look at those visits and look at your imaging and look at what happened while you were there, and to bring that to your visit. And then I would encourage everyone to write down your symptoms, track when they're happening every month. And those logs really help us when we're looking at your whole story. And I just want to thank everyone for coming on today. It's been such a great talk, and I hope you guys, I missed the beginning, but I'm so thankful for you guys for taking the helm of this while I was in the OR and leading this talk. It was awesome. And we really appreciate it. I hope that even all the ER doctors, it's so awesome to have you on here, right? And to educate other ER and primary care doctors who are really on the front line all the time. And, even though they may not be diagnosing endo, look, they're saving everyone all the time from all kinds of difficult things. And, even though endo may be complex and gaslit and difficult to diagnose for many years, it's not their fault. It's the imaging and the modalities and the difficulty of even a quality MRI, which may not show endo. So thank you both so much for coming.
Thank you.
Happy Memorial Day weekend, everybody.
Yes, likewise.